Zoom in WhatsApp in meeting ID password okay. Trial already trial. Okay. Okay. I got it. I'm ready. I'm set. Sir, carry it back to the gate. അതേപോലെ ദീപക് ചോദിച്ചേ, ദീപക് ഇൻട്രൊഡക്ഷൻ കഴിഞ്ഞ ഓവർ ടു ഡോക്ടർ ജോസ് പോൾ എന്ന് പറഞ്ഞിട്ട് സാർ എന്തെങ്കിലും ലൈവായിട്ട് പറയണോ അതോ ഡയറക്റ്റ് ആയിട്ട് വീഡിയോ ഒക്കെ പ്ലേ ചെയ്താൽ മതിയോ? അല്ല അത് അതിനേക്കാൾ നല്ലത് സാർ അങ്ങ് ഇടുന്നതല്ലേ? സാർ ഇട്ടിട്ട് സാർ അങ്ങനെ പറഞ്ഞിട്ട് സാർ എന്നിട്ട് അഡ്മിൻ പ്ലീസ് ഓൺ ദി വീഡിയോ എന്നോ അല്ലെങ്കിൽ എന്തെങ്കിലും പറഞ്ഞ് ഒന്ന് പറയുമ്പോഴത്തേക്ക് ഞാൻ പ്ലേ ചെയ്ത് തുടങ്ങിയാൽ മതിയല്ലോ. ശരി ഓക്കെ. ദീപക് അപ്പം പുള്ളിക്കാരൻ ദീപക് ഓവർ ടു ജോസ് പോൾ എന്നാണ് പറഞ്ഞാൽ ഓക്കെ. ദീപക് വന്നിട്ടുണ്ട്. തിരിച്ചു വെക്കണേ ദീപക് ഫോണ്. മ്യൂട്ട് ചെയ്യണോ? ഞാനത് മ്യൂട്ട്. ഇതൊക്കെ ഏതിലൊക്കെയാ കയറിയേക്കുന്നത്? ഞാൻ മ്യൂട്ട്.
ഈ എൻട്രി ചെയ്യുമ്പോഴുള്ള ഒറ്റ കളയാൻ മാർഗമൊന്നുമില്ല? ഹലോ, കേൾക്കുന്നുണ്ടോ?
എന്താ പക്ഷേ
മറ്റേ ഈ നമ്മൾ ഈ ആൾക്കാരെ എൻട്രി ചെയ്യുമ്പോഴും ഞാൻ അഡ്മിറ്റ് ചെയ്യുമ്പോഴും കിണി 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 എന്ന് ഒച്ച കേൾക്കുന്നുണ്ടോ? അത് എനിക്ക് മാത്രമാണോ കേൾക്കുന്നത്?
വരുന്നുണ്ട്. അത് അഡ്മിറ്റ് ചെയ്യാൻ ആള് വന്നു കഴിയുമ്പോൾ നമ്മൾ ആ ക്ലിനിങ് എന്നുള്ള സൗണ്ട് വരും.
അപ്പൊ കഴിഞ്ഞ ആഴ്ച ജയേഷ് പറഞ്ഞു അത് എന്താ ഒച്ച കേട്ടിരുന്നേന്ന് ചോദിച്ചേ. അപ്പൊ എനിക്ക് തോന്നുന്നു ഹോസ്റ്റലിൽ മാത്രമല്ല എല്ലാവർക്കും കേൾക്കാൻ തോന്നുന്നു. അപ്പൊ ഇങ്ങനെ ഫുൾ ടൈം അത് വന്നോണ്ടിരിക്കുമല്ലോ.
അഡ്മിൻസിന് മാത്രമേ കേൾക്കുള്ളൂ. അഡ്മിൻസിന് മാത്രമേ ആ സൗണ്ട് വരുള്ളൂ. നമ്മളിപ്പോ കോ അഡ്മിൻസ് ആക്കിയിട്ടുള്ളവർക്ക് മാത്രം ആ സൗണ്ട് കേൾക്കുള്ളൂ. എനിക്ക് തോന്നുന്നു ജയേഷിനെ അന്ന് അഡ്മിൻ ആക്കിയായിരുന്നല്ലോ, അപ്പൊ അതുകൊണ്ടായിരിക്കും ജയേഷ് അത് കേട്ടത്.
ഓക്കെ. Hello, sir. Oh, sir, unmute. ഞാൻ അൺമ്യൂട്ട് ചെയ്യാവേ. ഇപ്പൊ കേൾക്കാം.
അൺമ്യൂട്ട് ചെയ്യണം. ജോസ് പോളിനെ കേൾക്കാൻ പറ്റാം.
പ്രദീപ് കേൾക്കാമോ?
കേൾക്കാം.
എന്റെ ഒരു ലാപ്പിൽ നിന്ന് ഞാൻ കേറിയിട്ടുണ്ടേ, അതൊന്ന് കേറ്റുവോ?
ഏത് പേരിലാണ്?
ഞാൻ ഒരു കാര്യം ചെയ്യാം, ഞാൻ എന്റെ ഇതിൽ തന്നെ ലോഗിൻ ചെയ്യാം. 1 സെക്കൻഡ്, ഞാൻ ഒന്നോടെ ലോഗിൻ ചെയ്യാം.
ജോസ് പോളിനെ ഇതാക്കിയാൽ മതിയല്ലോ.
അതെ, അത് ഞാനാ പറയണ ഇത് ചെയ്യണേ, സൈൻ ഇൻ. അല്ല, ഒരു സെക്കൻഡ് ഞാൻ ഇപ്പൊ തന്നെ കേറാം. ഈ പാസ്കോഡ് എത്ര മീറ്റിംഗിന്റെ?
മീറ്റിംഗിന്റെ പാസ്വേഡ്
എനിക്ക് കിട്ടി.
പ്രദീപ് അൺമ്യൂട്ട് ചെയ്യണേ. പ്രദീപ് പറയുന്നത് കേൾക്കുന്നില്ല.
പ്രദീപ് ഇപ്പൊ എന്റെ വേറെ ആരും വന്നില്ല, നിങ്ങളുടെ ഒന്ന് എൻട്രി ചെയ്തേരെ.
ബാക്കി എല്ലാരും മീറ്റിംഗ് റൂമിൽ കിടക്കുക സാറേ.
അല്ല, എന്റെ എൻട്രി ചെയ്യിച്ചോ, എന്റെ സൂമേ
എൻട്രി ചെയ്തു.
ഓക്കെ റൈറ്റ്.
എൻട്രി ആക്കി. പ്രദീപ് പോയോ?
ഇല്ല, അപ്പുറം ഉണ്ടെന്ന് തോന്നുന്നു. ഇല്ലേ,
ഞാൻ ഓക്കെ കേട്ടോ.
ആണോ?
മാത്രമേ
എനിക്ക് കിട്ടുന്നുണ്ടല്ലോ. ജിയോയുടെ ഒന്ന് സ്റ്റാൻഡ് ബൈ വെച്ചു കേട്ടോ. ജിയോയെ
രണ്ടുപേരും ഒരു സ്ഥലത്തല്ലേ, അത് കഴിഞ്ഞിട്ടാണ് സൗണ്ട് കേൾക്കുന്നത്. 5 മണിയായി.
ജോസ് പോൾ സാറിന്റെ മറ്റേ കേറിയോ? കേൾക്കുന്നില്ല, ജോസ് പോൾ കേൾക്കുന്നില്ല, മ്യൂട്ടാ.
ജോസ് പോൾ സാറിന്റെ 6 ഉള്ളല്ലോ, ഒരു
കേറിയിട്ടുണ്ട്. ഓക്കെ,
നീ അഡ്മിറ്റ് ചെയ്യട്ടെ, അഡ്മിറ്റ് ഓൾ അടിക്കട്ടെ.
ഒരു മിനിറ്റ്
അഡ്മിറ്റ് അടിച്ചോ.
ഇതിപ്പോ ജോസ് പോൾ സാറിന്റെ കമ്പ്യൂട്ടർ ആണോ ഇത്? പോയല്ലോ പിന്നെ.
കമ്പ്യൂട്ടർ അല്ലല്ല, ഞാൻ ഇവിടെ ഉണ്ട്.
ഒരു മിനിറ്റ്, ഞാൻ അതൊന്ന് കോഹോസ്റ്റ് ആക്കട്ടെ.
അതൊന്ന് കോഹോസ്റ്റ് ആയി.
കോഹോസ്റ്റ് ആയില്ലേ? ഉണ്ട്. അപ്പം ഞാൻ എല്ലാവരെയും ഇപ്പം അൺമ്യൂട്ട് ചെയ്തിട്ട് നമുക്ക് കോഹോസ്റ്റ് മാത്രമേ അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റുള്ളൂ സ്വന്തമായിട്ട്. കാരണം നമ്മൾ ആ നോക്കിയ വീഡിയോയുടെ മുകളില് സാറിന്റെ തലയുടെ ആ പടത്തിന്റെ മുകളിൽ പിന്നെയും
ആയിക്കോട്ടെ സ്റ്റാർട്ട് ചെയ്തോ
ശരി.
ഞാൻ മ്യൂട്ട് ചെയ്തിട്ടുണ്ട് കേട്ടോ, ഓൾറെഡി മ്യൂട്ട് ആണ്, മറ്റേ ആർക്ക് അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റൂല, അങ്ങനെ ആക്കി വെച്ചിരിക്കണേ. നീ മാറ്റിയോ?
അങ്ങനെ തന്നെ ഇരുന്നോട്ടെ.
ഓക്കെ, ഐ അഡ്മിറ്റ് ഓൺ.
ഒന്നുമില്ല സാറേ, എന്ത് പറ്റി? തുടങ്ങിക്കൂടെ, അതിന്റെ സംഭവം ചെയ്തോണ്ടിരിക്കുവോ സാറേ? ഇപ്പൊ കേറുവാ. ഓക്കെ, അഡ്മിറ്റ് ചെയ്തോ.
42. Very good evening to one and all. IDM Malanad welcomes you all to our fourth CD on Unlearning Basic Concepts in Periodontology by Dr. Joseph. And before starting, I request all of you to switch off your cameras and microphones. And in case of any doubts during the session, please feel free to write in the chat box. The questions will be cleared at the end of the session. Now I invite Dr. Deepak Kalarikal, IDM Malanad President, to address the gathering and also to introduce the speaker.
Thank you, Dr. Moshmi. Respected Secretary, Dr. Pradeep Philip George, Speaker of the Day and Student Dean of Unlearning Dental College, Mathura, Dr. Jose Paul, CD Chairman, Dr. Moshmi CB, and dear members. A very good evening to all of you. I would like to welcome you all for today's webinar. Our speaker for the day, Dr. Jose Paul, was my immediate senior in Vinayaga Missions Dental College, Salem, and he completed his graduation in 1996. He did his post-graduation in periodontics from Government Dental College, Trivandrum in 2001. He is the recipient of Young Scientist Award in 2003 from Government of Kerala for the work on platelet-rich plasma in periodontal regeneration. He had won the IDA National and State Awards for Best Editor of Local Branch Journal in 2018. He has also won the National Award for Best State CD Chairman in 2019. Presently, he is the Students Dean and Professor and Head of Department of Periodontics, Unlearning Dental College, Mathura. He was the past president of our branch in 2008 and has won our branch many awards in shuttle badminton and cricket. He is an amateur cyclist and had completed 600 kilometers cycle ride in February. I would like to welcome our distinguished speaker for today's webinar, Dr. Jose Paul. Over to Dr. Jose Paul for the session. Thank you.
Thank you, Dr. Deepak. It was indeed a very good, or in fact, warm introduction. Well, it's nice to be part of our own branch and address the members of the same branch. Like IDM Malanad branch has been dear to me, and I've been very active with this branch for over 20 years. And this is probably the second or third time that I'm speaking, addressing members of IDM Malanad branch. Now being this pandemic and being in a Zoom platform, often we have a lot of technical glitches while presentation. So this time what we have decided is what I've done is I have pre-recorded my entire lecture. Okay, and that will be played And after the lecture, I'll be here entirely throughout. And after the lecture, if you have any doubts, we will interact after the lecture. So that is how we have planned today's session. And I think we'll start the session without much ado. I request the admin to please start the proceedings, start the meeting. Good evening, everyone. At the outset, I'd like to thank the principal office bearers of IDM Malanar branch, President Dr. Deepak, Dr. Pradeep, and of course the CDE chairman, Dr. Maushmi, for giving me an opportunity to present my experience with my own IDA members. So the topic today is unlearning the basic concepts of periodontology. So what exactly is unlearning? Unlearn means now over a period of time, some of the things that we learn become obsolete. So we need to change, or we need to learn what is being different from what we have learned. Now, many of you have been practitioners, and many of you have been practicing with probably senior dentists, and you would have seen some things that they have done, and you would have inculcated the same methods or practices into your own patients. Now, they may not be always right. So this presentation is basically to unlearn certain basic things which probably you have been doing wrong, especially in regards to periodontics. Now, one of the main reasons why I'm doing this presentation, now I was first invited by IDA Artingal branch to do a presentation. They selected a lot of topics for me, and then I finally said they selected flap surgery, minor surgery, regenerative periodontal surgery, all those types of different types of topics. I said, look, I've been practicing periodontics for probably about 20 years. I've been visiting many clinics, and in my early career, I used to visit probably about 20 to 25 clinics. And from my experience, I know that probably my data may be wrong, and maybe I stand to be corrected. About 95% of the dentist population, that is the non-periodontist population, are not skilled to identify an early periodontal lesion. Early periodontal lesion. So I'm going to throw some light on identifying or tips in identifying periodontal lesion. Now, this is not a theoretical lecture. I don't plan to give a theoretical lecture. Now, we are going to discuss about some pertinent basic periodontology here. And if at the end of this lecture, at least 10 of you are able to diagnose and plan a treatment for a simple periodontal problem, then I've done justice. That is how I consider myself. With this as a preamble, let's go. Now, as I told you before, no, I didn't tell you before. Now here, anybody can identify an advanced periodontal case. Now, if you see this photograph, now this probably is an advanced periodontal case. Now, from a third BDS student to anyone who is practicing dentistry, will be able to identify this as an advanced periodontal case. Good. Now, suppose you see this case. This case has some features of periodontitis. You can see some spacing between teeth. You can see some inflammation in relation to the gums. Okay, so much and so features are there. We'll probably go for a radiograph. And in the radiograph, you may find some sort of bone loss. So this is also type of cases probably the dentist nowadays will recognize or diagnose. Now I'll show you one more case. Now this is another case, and probably to everyone over here who is watching, now this looks like a normal gingiva, normal periodontium. But probably to a periodontist, he may find there is something here, some alterations from the normal, some deviations from the normal may be noted over here. Now, some rolled out margins may be there. A loss of stippling is present here. So it gives a basic little bit idea of something that is cooking up underneath. So probably if you go for a radiograph, now if you go for a full mouth radiograph, in relation to this area, which looks probably very normal, this is the radiographic picture. And this is what you see on surgical exposure. Look how much of bone is lost here. And just imagine this case. You have not diagnosed this problem and you are going to do an orthodontic tooth movement in relation to this. Now the tooth is going to become mobile over here and probably you may lose the tooth. Now these are the lesions which I want you to diagnose. The first and the second most on the top, every Tom, Dick and Harry can diagnose. But after this presentation, probably I want each and every one of you to diagnose early periodontal problems so that it is not only beneficial to you, but at the same time, it's greatly beneficial to your patients. So first, we'll discuss about clinical diagnosis. Now, clinical diagnosis is the best method. Now, you can take radiographs to supplement this diagnosis, and microbiological and other biochemical diagnoses are all theoretical point of view. It's probably a research point of view as of now, but I just want you to mainly focus about clinical examination. Now, what I really want to every one of you to look when you examine the teeth or the oral cavity is, please don't just focus on the dentition or the tooth only. Please focus on the gingiva. Look into the different aspects of the gingiva. Look, you can see here there is no recession. You can see some stippling. Here, in spite of there is a spacing, this is not pathologic migration. You can see the stippling over here. If there is stipple, there is absolutely no pocket here. Now you can find this depression over here in relation to this area. That gives you an idea that there is no pocket here. If there was a pocket or inflammation there, that area would have been inflamed. So basically, what I want you to do is, I want you to focus upon these areas. Focus upon the gingiva. Look at the subtle changes that may be seen in the gingiva. You can identify a periodontal lesion just by looking at the gingiva. Now, these are all early signs of, you can see the color changes in the gingiva. Probably the size may be enlarged. And you can always contribute these changes with the local irritants that are present here. They're all cases of simple gingivitis. So you can observe there. that these are cases of gingivitis. And with looking at the gingiva itself, you may know that there is not much amount of bone loss in between teeth, and probably there is no loss of attachment, and these are all cases of simple gingivitis. But when you look here into this gingiva, look at the interdental papilla, it is all inflamed. Here now, slight spacing has occurred. You have, when you see the slight spacing, probably you will have to go or diagnose or put your mind deeper into these areas. Go for a probe these areas. When you probe, look, the probe is going on deep. And look at the color change in relation to an area where the pocket is. And I know that there may be many periodontists also here watching this. And myself, along with all these people, are trained in such a way that just looking at the different aspects of the gingiva, we are able to diagnose periodontal pockets. I don't want you to diagnose it like that because you're not trained that way. But at least if you look into the different aspects of gingiva, you will know that there are subtle changes which really gives way or gives information that there is an underlying pathology over there. For that, what you need is a simple probe. Now, I did a presentation in Idea Malanad. I don't know. I think Dr. Jiju was the president during that time. It was a long time back. And I said that how many of your dental clinics have got a good calibrated periodontal probe? I asked that question, nobody answered that. But then after the CD, probably about 1 or 2 months, people have personally come and told me that we have incorporated this into practice. Now, I showed you a picture of a normally looking gingiva with advanced bone loss and pocketing. Now, if you don't include this basic instrument into your armamentarium, how are you going to diagnose that? So this is something that should be there in your diagnostic instrument, along with your periodontal, with your mouth mirror, with your explorer. This is a third instrument that should be there. Good. Now, this is basically, as everyone over here knows, that this is basically to check for periodontal pockets. But you know, when you think about periodontitis, there is one aspect that you have to think, that is that in relation to posterior teeth, especially in relation to multi-rooted tooth, there is another dimension known as furcation involvement. Now, that is a pocket or a periodontal lesion extending into the furcation area. That also has to be detected. Now, for detecting that, the best probe is a neighbor's probe. I don't advise anybody of you to buy a neighbor's probe, but with the round end of your explorer, you can diagnose the periodontal, furcation involvement. Now, what is a method of probing? Now, whenever you are probing a tooth, you have to probe in different aspects of the same tooth. Now, in this picture, you can see that the probe is going deep down here. Probably the probing depth here is probably about 8 millimeters. Now here, the probing depth may be about 6 millimeters. Here it's 4 millimeters. Suppose you insert the probe down here and you try to move the probe here. Will it move? It won't move. That is why you have to do a method which is known as walking the probe. You take the probe, insert in one area, basically the mesiobuccal area, then probably in the mid-buccal area, and the distobuccal area. The same thing you have to do in the lingual and the palatal aspect. And this process of probing is known as walking the probe. Now, I'll show you the importance of walking the probe. Now, this is a patient that came with a mild spacing and some extrusion of the upper anterior teeth. And look, On surgical exposure, this is what we found. Now, suppose you probe this area. Now, as this probe is gone, this probe will go deep, about more than 10 millimeters. Now, suppose the same person is probing this area will be probably 8 millimeter. If he probes this area, it will be about 3 millimeter. So that is the difference. So suppose if you insert the probe here and try to move this, you can't move. That is why you have to do walking the probe. This is the method of probing around tooth. Mind you, in your practice, in your periodontal practice, people will come asking you for replacement of missing tooth, management of painful tooth, especially carious tooth, management, they want to manage procline tooth, all this tooth. No patient is going to come and tell you, doctor, I have got a periodontal problem. I have got periodontal pocket. But usually the patients may express their concerns as probably, doctor, I've got bleeding gums. I've got bad breath emanating from my oral cavity. My teeth are shaking. Over a time now, the upper and lower teeth, and they are spreading out. There's spacing between the two. Sometimes you may say that, that when I press this arrow, sometimes there will be swelling in relation to tooth. Now, these are small indicators that there is an underlying periodontal problem. And when these patients tell you that they have got these problems, it is the responsibility of you, dentist, to identify whether there is a periodontal pocket there, whether your gums is receded, the extent of mobility that is present in relation to the tooth, whether you can press on the surface of the gingiva and you can see whether there is pus coming out, a little bit of pus, exudation, means that there is an active infection over there. Or, as I said before, you can also check for furcation. So, based on these complaints, basic complaints from the patients, you yourself have to identify these periodontal problems. Problem is, you probably may be going to do a fixed orthodontic therapy. Now, I'm not saying that may fail, but that may not come to the best outcome as you would have ever imagined if you are not treating the underlying periodontal problem. Now, if you are doing a fixer, if you are doing a FPD in relation to that tooth or in relation to these teeth, now what will happen? Over a period of time, the FPD is going to fail. If you're doing an implant, there are a lot of studies which says that if you are not able to control the periodontal infection, there is almost 45 to 50% of chances that there is going to be peri-implantitis developing in relation to your implant that you have placed. So basically, from all these clinical symptoms that the patients say, you have to identify that there is a periodontal problem. And you have to identify this periodontal problem with your visualization and also with your periodontal probe for checking pockets. So I think I've made myself clear. It is very simple. Now, we just look at etiology. What is this? What is causing this periodontal problem? Now, this is a paradigm which describes the pathogenesis of periodontal disease. This was, I can say that it's a little bit outdated also, but I think in the present scenario for all these general practitioners or non-periodontists to understand, this is one thing that is best. Now, whenever you have a bacterial assault, now we all know that Periodontitis is caused as a result of microorganisms that are present in the plaque. Now, what will the plaque do? When there's accumulation of plaque, the bacteria produce a lot of toxins. And one important toxin is enterotoxin. So the bacteria produce toxin against the host. And what will the host do? The host won't be silent. The host will act against this bacteria. There is going to be a host-bacterial interaction. The host will act against this bacteria by means of humoral as well as cellular immunity. It produces antibodies. All the immune cells become stimulated. Your PMNs, the lymphocytes, the macrophages, all these become stimulated and it will attack the bacteria. And in simple cases like gingivitis, the host may overwhelm the bacteria and the disease is controlled. But in some cases, if the bacterial load is too much, if there is some problem associated with the host, what happens is the host produces a lot of mediators which kill the bacteria, but at the same time, it creates or it induces something called as bystander damage. That is, it not only acts against the bacteria, it acts against its own host cells, own periodontal cells, and destroy the periodontal tissues, which result in disease. So that is basically what is happening. And this whole host bacterial interaction is being influenced by two things. One is what you see on top, acquired and environmental risk factors. Smoking, diabetes, all these can influence this host bacterial interaction. Another thing that can influence is genetic risk factors, especially when there is defects, especially defects with neutrophils. Any defects, any syndromes, neutropenia, cyclic neutropenia, Chidiac-Gashi syndrome, all these can influence this host bacterial interaction and can aggravate the destruction and the rate of progression of periodontal disease. So this is basically what you know. So what I want you to know is basically the periodontal disease is caused as a result of bacteria that are present in dental plaque. Okay, when you look into a tooth, that probably when you see a patient, will you be able to identify dental plaque? No. Plaque is not visible to the naked eye. Plaque has to be disclosed. That is why we need disclosing agents. What you see is not plaque. It is basically plaque with little bit of food debris and other things, which we call it as materia alba. And materia alba can be easily removed from the tooth surface, but plaque is very much tenaciously adherent to the tooth structures. And at a point of time, when you take a plaque sample, you may find about 500 to 600 different species of microorganisms within a one plaque sample. But what I want you to know is not all these microorganisms, different microorganisms that are present in plaque are pathogenic. Only about 10 of these microorganisms are periodontal pathogens, and these are causing periodontal disease. The rest of all these 490 to 590 microorganisms are probably very much needed for the homeostasis of the body, for the ecosystem. Now, what is the role of calculus? Does calculus have a primary role or calculus have got a secondary role? For that, we have to understand what is calculus. What is calculus? Calculus is nothing but it is calcified dental plaque. So over a period of time, if you're not removing the plaque, this plaque becomes calcified and it becomes calculus. It becomes adherent calcified mass like this. There are different theories and different lots of things regarding formation of calculus. I'm not going to discuss about it. What is the role of calculus in causing periodontal disease? That is what we have to discuss today. What is the role? Does calculus have got a primary role? No, calculus doesn't have a primary role. That is one thing you have to understand. Always, this calculus is covered by means of a non-mineralized layer of plaque. And what this calculus does is it presents this plaque to the gingival tissues. Now, suppose you have a periodontal pocket. Within the pocket, you may find calculus. And what will that calculus do? The calculus acts as a fixed nidus on the root structure. And it is always covered by means of a non-mineralized layer of plaque. And this presents the plaque to the gingival tissues. That is the role of calculus. So that is your role in periodontal therapy. So we know now that plaque has got a primary role, calculus has got a secondary role. Now, if you are able to control both of them, you can control periodontal disease. That is what I've got to say. Now, as a clinician, you can't, on a day-to-day basis, you are not able to control the amount of plaque that is formed in the oral cavity of your patients. You can't. But you can remove the calculus. The patient can't remove a calculus once it is formed. By thorough oral prophylaxis, by scaling and root planing, you are able to remove calculus. So it is your duty when a patient comes to remove calculus. Remove calculus means remove calculus entirely, not only in relation to the areas where it is seen, in relation to the areas where the patient also doesn't know where it exists, in lower lingual aspects, in relation to the distal aspects. Everywhere you have to scale. You have to do a meticulous scaling so that you remove every speck of calculus. And then you advise the patient to maintain proper oral hygiene. Then you will get better habit. So I hope I've covered the etiology. Now, this is something that I've just added for a completion's sake. Now, over the years, when I was studying, in the early part of when I was doing my MDS, we were following a classification based on 1989. Then, towards the end, towards our exam, we started following a classification which was proposed by the American Academy of Periodontology in 2019. Now, we followed it almost for 17, 18 years. And recently, in 2017, there's another classification that has come, which is being adopted. So I'm not going deeply into the different classification system. Now, from a layman point of view, or from a general practitioner point of view, how this classification is very simple, and this may help you in identifying and managing periodontal problems. So I've just put forward this. This is not the actual classification according. I don't have any reference for it. The reference is my experience. Okay. So according to this, you have gingival disease on one hand, you have periodontal disease on one hand. Gingival disease is a disease that is limited only to the gingival tissues, and you properly manage that cases, all the gingival tissues revert back to its original form, structure, and architecture. But in case of periodontal disease, you have two types of disease. You have a slowly progressing, which is mainly seen in adults, known as chronic periodontitis, and a type of periodontitis which is more aggressive, which the rate of progress is much high. The amount of local irritants are very less, and which is mostly seen in younger individuals, which is known as aggressive periodontitis. So that is how we'd like to sum this classification of periodontal disease. And based on this, we will discuss further. So in gingivitis, as I said before, how do you manage gingivitis? Gingivitis is just inflammation in relation to gingiva that is caused as a result of plaque. If there is only plaque, you advise good oral hygiene. Everything will revert back. There is calculus, It is your duty as a dentist to remove all this calculus and then advise the patient to maintain good oral hygiene. Everything will revert back. Review the patient. Treatment is over. Okay? Now, you see a condition like this. What will you do? This is mainly caused as a result of the supra and subgingival deposits. Do a proper scaling. Look how well the inflammation is subsided and the gingiva has become healthy. In some areas, you can see that it has progressed beyond gingiva to periodontitis. Now, this is the difference between chronic and aggressive, which we have already described. Okay, aggressive is mostly seen in young individuals where there is reduced lactate factors, and the rate of progression is usually much more when compared to chronic, where usually mostly in case of adult patients. Now, this is a typical chronic periodontitis that we see. I was showing some photographs earlier also. These are all chronic periodontitis. When you see in the radiograph, you may find generalized bone loss. And this is something that I want you to look into radiographs. Now, suppose you look into radiographs and find something like this, especially after your scaling. You take a radiograph and find there is some irregularity into the root surface like this. These are all calculus subgingival deposits. Even in the IOPA, the OPG, you can see some spikes here, some small specks here. These are all calculus. Now, if you have done a scaling and you're taking this radiograph, you can be sure that there is some sort of pathology that is underneath. This calculus is there. This calculus is covered by means of plaque, always covered by means of plaque. So whatever, even if the patient is maintaining meticulous oral hygiene, the progression of periodontal disease is going to continue because there is a lot of microorganisms within that periodontal pocket. Okay? In aggressive periodontitis, I said this. Now, like in localized, what you see, flaring up and lower anterior flaring, arch-shaped bone loss, all those things can be seen. But the peculiar feature of aggressive periodontitis, there is minimal deposition. In all the other pictures I showed, there are a lot of deposits, but you can see in case of advanced destruction also, you may find very minimal amount of local factors. How will you manage these chronic as well as aggressive periodontitis? Now, this is a sequence. This is of just theoretical value. I'm not going too deep into this. What to do is in the first phase of your periodontal therapy, you have to remove all the etiology. Etiology here is mainly plaque and calculus. That is, you do a scaling, do a root planing, and then advise patient good oral hygiene measures. And if there is any other contributing factor that is leading to plaque accumulation or tissue or periodontal tissue destruction, address that. That is the etiotropic phase. Now, immediately after etiotropic phase, based on whatever you're finding on the first day, you are not planning your final therapy or final treatment plan. Your final treatment plan is going to base upon re-evaluation. Now, that is something that I want to stress over here. What do you do in re-evaluation? You recall all these patients after scaling and root planing. And then you recheck. What only recheck? You recheck. Look at how the clinically, the color, the contour, the consistency of gingiva has changed. You look how the pockets have changed. Whether it is increased, it's remained the same, it is decreased. And based on these, you also check about how the patient is maintaining well. Is there any need of further treatment? This patient is not maintaining at all. There's no point in doing further treatment for this patient, such patients. So is there any need for doing any treatment in this patient? All these things you reevaluate. And then, depending upon the condition of that patient, you can put them, you can group those patients into different some patients may need surgery. Such patients will go into re-surgical phase. Some patients won't need a surgery. They may need some restorative treatment. Do restorative treatment and then put the patient on supportive therapy or maintenance therapy. So that is a sequence in which you have to do periodontology. Now, I'm going to use certain terminologies which are like based on my experience, like early periodontitis. That is not present as per the present classification. Like what according to me, what is that? Now, if you have a very shallow pocket, like not very deep pocket, you have just about 4 millimeter pocket where the gingiva is bleeding, and sometimes there may be presence of recession without any pocket. In all these cases, what will you do? Your treatment is almost similar to how you manage gingivitis. How will you manage? Do proper etiotropic phase, that is, you do good oral prophylaxis, recall the patient, do a subgingival scaling, and do a root planing, and then review the patient. That is not 4 millimeter pocket will come to a normal pocket. So that is what you have to do in very early case of periodontitis. Now you can see now a lot of deposits are there. You can see look at the gingiva here. Look at the inflammation. I just want you to look at, whenever you're looking into this, in the periodontal aspect, you have to look into the color, contour, consistency of gingiva. You not be able to appreciate everything in a photograph, but just have a look into that. Now, with just one scaling, a lot of things have changed. Little bit of deposits are remaining there. Okay. Now, suppose you see this case like this, lot of deposits, bleeding and probing. Look at the gingiva; it's slightly enlarged over here. It's bulbous, it's edematous. If you press against this lateral aspect of this gingiva, there's some sort of exudation. All these things are there. What will you do? One simple scaling to planing. Look at the amount of difference that has occurred over here. So that is the importance of re-evaluation. Now, in such cases, if you make a treatment plan based on what you see on the first day, that is what the picture that you see in the left-hand side, what is that? You may find about 5 or 6 millimeter pocket in relation to many teeth. Some of these may be pseudo pockets because these gingiva is enlarged. Okay. Now, I have seen many cases. I have visited many clinics in which the dentist will call the periodontist to do a surgery in this case. What will happen if the dentist do a periodont? I mean, if the periodontist do a surgery here? No, he can't put a proper incision there. The gingiva is all inflamed. It will bleed like anything. The surgery is not going to be perfect here. And more than everything over here, probably this patient won't need any surgery if you have done a proper etiotropic phase. Do a proper scaling. Look at what has changed over here. Look at the gingiva over here. Look at the health of gingiva. Just look at the stippling. There is no surgery that is done here. Look, you can see here there is inflammation. There is you can find some subgingival calculus. This gives an indication that probably in these areas you need a surgery. But look how much has changed. And if at all you need a surgery, just like when you put an incision, how less the bleeding will be here in the circulation. So with a proper scaling and root planing, with proper scaling means complete removal of calculus and advising the patient to maintain good oral hygiene, 90% of the periodontal problems can be addressed. You can eliminate 90% of the lesions. And another good thing is this thing is going to acquaint the patient with your office. The patient is comfortable when the periodontist comes and he comes to do a surgery. Periodontist is happy because all the inflammation is subsided. Now he can put an incision on sound bone. There will be less bleeding. He can do a perfect surgery. So this is the importance of remediation. So whenever you are doing
whenever you are seeing a periodontal case, the first and foremost thing that you have to do before referring this patient to a periodontist, or in some cases probably referring this patient for extraction or doing extraction in this patient, is do a proper scaling. Proper scaling means complete removal of calculus attached to tooth surface whenever possible. If you have a deep pocket and calculus is deep, you can't do. But whatever possible, if you can do, this is going to bring wonders to a patient. It can eliminate most of the lesions. So that is the importance of scaling and replaning. It is not rocket science. Look at this case. You see a lot of, you can see the interdental gingiva is so grown, enlarged. One simple scaling, removal of subgingival deposits, and advising the patient on maintenance regime. Look at how much change has occurred here. Another case. Look how much the gingiva is enlarged. You can see that there are deposits at that age. So you definitely, with this photograph itself, it's very much indicating that there are a lot of subgingival deposits also. This patient doesn't have any history of taking drugs or any other systemic problem. Now, one simple scaling, meticulous scaling. Look how much the inflammation and the growth of this gingiva has subsided or reduced. You can look at this morphology, it's enlarged here. Probably after this, if needed, you can go for surgery. So 90% of the cases, just by doing meticulous scaling and advising the patient to maintain good oral hygiene, you are able to eliminate most of the periodontal problems. Then that is what I want to reiterate here. Another case, look at, you can see the enlarged a little bit. Touch here, it's going to bleed like anything. Do a scaling. Just remove the deposits. Look at how the gingiva. You just look at the interdental papilla in relation to upper and lower areas. Look how well it has changed. This is by doing at scale. The problem we face, or as a dentist, everyone does this, we don't follow up cases. So we don't know how, like, especially after doing a scaling, you don't follow up cases. You are scaling and recall him for some scaling. Just say that something is there for review. That is mandatory. And you just look, if possible, you take a prior photograph, and after scaling, after 2 weeks, you recall the patient and see how much changes. You'll be surprised. This will be an eye-opener for you. That's what I'm going to say. Now, another case. You see a lot of, in the radiograph, you're finding bone loss is there. There's a lot of deposits or calcified deposits are there. You can see, look, here are a lot of deposits. Look at the gingiva here. One, good scaling. When you take a radiograph, what you see horizontal bone loss. Bone loss is there, loss of attachment is corresponding to this recession. Bone loss has occurred over there. But look at the gingiva in relation to this interdental area, in relation to this, all these attached tissues. Look at the gingiva. It looks so healthy. Is there a periodontal problem there? Is there any further treatment that is needed? Or whatever treatment that you do to cover this tissue, is it going to be successful? Never. You do a proper scaling, in this case, everything is over because there are not deep periodontal pockets. It has resulted in recession, but if the patient maintains well, that is more than enough. There is no further treatment that is needed. Even if the best of periodontists do with the best of biomaterials available, there is not going to be much result over here, I can guarantee you, with my 20 years of experience in periodontics. Now, next is established periodontitis. Now, what do you do in established periodontitis? Now, the criteria according to me is you have a pocket of more than 5 millimeters, especially after your phase 1, you find this pocket. Then even after doing a scaling, there is bleeding. Even after scaling, you press on the lateral aspect of the gingiva, some amount of pus is coming. or when you probe with your periodontal probe or with your explorer, you can see some deposits or rough, your root surface is rough in relation to the pocket. That means your scaling is incomplete. There is some amount of pathology remaining within the gingival tissue. There is some amount of calculus remaining within that pocket that needs to be addressed. So in that cases, what you can do is, even after periodontal surgery, you are, after your phase 1 or a scaling, you're finding a pocket of more than 5 millimeter. Such cases are cases that are good for surgery. Not the cases that you find on the first day and you probe and you check for pockets of more than 5 millimeter. That are not the cases that are indicated for periodontal surgery. On re-evaluation, you find pockets of more than 5 millimeter. Such pockets, such cases are indicated for surgery, where you can do a flap surgery with regenerative, resective, or all those. That is not my topic today, because I'm not going to discuss about what is flap surgery, what are the different types of flap surgery, how you put incision, everything is beyond this lecture. Now, what do you do? This is a case of deep pockets which needed surgery. This is after phase 1. Now, this is the clinical picture after the surgical phase. One teeth was poorly, this tooth had got a very poor prognosis, it was extracted also. Now look at the other tooth. This tooth is extruded. And there's a localized periodontitis in relation to this tooth. There's a deep pocket in relation to that. The tooth was slightly out, anesthetic. And this was the X-ray taken. You can see the bone loss. And because we need to correct it aesthetically, we plan to do an intentional root canal in relation to the this tooth. This tooth was vital only. And we did a procedure known as a papilla preservation flap, where the papilla was preserved, because especially there was spacing between these tooth. In such cases, you can do a papilla preservation flap. And this is, you can see the defect here. You can see an angular defect here, which was filled with bone grafts, and then it was sutured, and this is how it healed. Now, thing is, with periodontal surgery, the gingival tissues, the basic foundation heals. But if it is, if you talk about the aesthetics, probably it's going to worsen the aesthetics. So probably after the periodontal therapy, because of the associated recession and things like that, you probably have to do a aesthetic therapy in relation to periodontal therapy in case of advanced cases, especially in relation to the anterior teeth. And this is the problem is resolved to an extent post-operative, and a crown was given. So that for that only the root canal treatment was done in this case. Excuse me. Now this is another case of advanced periodontitis. Look, you can see the probe is almost gone fully. Okay, and after you can see pus coming out, exudation. So it's a chronic abscess over there. And after scaling and a good subgingival scaling, this is healed like that. And because there was a pocket going deep almost to the apical aspect of the root, a root canal treatment was advised. And this was a radiograph after the root canal treatment. So you can imagine it's almost you will get a similar radiograph before the root canal. I didn't have a radiograph before that. That's why I put this. Sorry, this was a radiograph. There was not much mobility, about grade 2 mobility also here. So we decided to do a flap over here, and we modified incisions in such a way that there will be minimal recession. We wanted to cover some recession also. So we preserved this interdental area where the pockets were more towards the apical aspect. So this was what we found. Look, just about the, just underneath these gingival margins, what was causing this pus? It was because of these calculus that is attached to the root surface. And by any non-surgical therapy, will you be able to blindly remove all this calculus? You can't. So in your surgery, Basically, what you're going to do is you are debriding these root surface, removing all these accretions that are present on the root surface. In this case, it was an endodontically treated tooth. So we just removed that. We did a little bit of episectomy also. And then we decided to graft this area. And we coronally pulled this area. You can see the recession is almost there. And we pulled it at almost about 1 or 2 millimeter left. And it healed well. To be honest, it healed well. Mobility decreased. We are following up this patient over a period of time. And it's keeping well. So that is one case of advanced periodontal disease. Now, another case what I want to show here is, you can see some little bit of pathological migration here. You can see there is endodontal bone loss, and you find a deep pocket over here. Now, there's OPG of the same patient. You can see that the problem was mainly in relation to the lower anteriors and in relation to this molar, this aspect of this molar. So when you take an IOP of this, this is what we found. And look at what we find here. In relation to this IOPA, in relation to this, you may find that the root surface, it's uneven. There is something attached to the root. Even here, there is something attached to the root. So we explored. And when we opened up, look, whatever you're seeing in the radiograph, the whole, it is covered by means of calculus. So it is this calculus and the plaque that is attached to the calculus that has caused this bone loss. There's nothing else that has caused this bone loss. So what we did, we cleaned this area well. You can see after cleaning, look at the change in the surface texture. I mean the surface of the root in relation to this, the same areas. And then we grafted that site also. In relation to the posterior aspect, look, you can see irregularities into this. Opened up deep periodontal packet because it was almost extending to the apex and it was non-vital. We did a root canal therapy, and then we did this is a post-op with some amount of bone graft. And look at the surface. That's what I want to observe. I want you to observe. Look at the surface. It's more clear. It's more even. So basically, periodontal treatment or periodontal management is not rocket science. It is something that is basic. Basic means the removal of calculus from the root surface. Mind you, I'll say all these things and show you all these pictures, but removing this calculus from the root structure is not very easy. But at least from a supragingival and a subgingival of 2 to 3 millimeter, it is easy for a practitioner or a general practitioner to do it, and it will resolve about 80% of all periodontal problems. And you can, I'm not asking you to do it with all your curettes. You can use with your ultrasonic scaler itself, you can do all these things. But of course, for a periodontal surgery, apart from scaling, you need root planing and things like that. And that is going to be different, and I'm not going to discuss much more into this. So basically what I want you to focus is you have to remove the calculus or whatever accretions that are present on the lateral aspect of the root that is causing the periodontal problem. Another case, look at the gingiva here. Look at the color, look at the demarcation of gingiva here. You can see definitely there is a deep pocket here. It's a bluish hue. Look how well it has healed. Maybe the photograph difference is there, but still that is there throughout this area. But look at how well it's healed and after surgery. Same patient in relation to this aspect, how well it is healed after surgery. There is recession. Of course, the recession is increased after surgery. But look at the gingival tissues. Now, this is what we want even after doing a radiotropic quiz. We want our gingiva that is probably knife edge, that doesn't bleed, that is really healthy. So that is what I want all of you practitioners to concentrate upon. Now, we now have WhatsApp and email. And now the main problem is someone will be sending you one radiograph and then asking you to diagnose and give a treatment plan. To be honest, I cannot diagnose a single
Pradeep?
Yes, sir. Just having a little bit problem with the net. 1 second. We'll be back online.
It is something that is basic. Basic means removal of calculus from the root surface. Mind you, I'll say all these things and show you all these pictures, but removing this calculus from the root structure is not very easy. But at least from a supragingival and a subgingival of 2 to 3 millimeter, it is easy for a practitioner or a general practitioner to do it, and it will resolve about 80% of all periodontal problems. And you can, I'm not asking you to do it with all your curettes. You can use with your ultrasonic scaler itself, you can do all these things. But of course, you know, for a periodontal surgery, apart from scaling, you need root planing and things like that. And that is going to be different, and I'm not going to discuss much more into this. So basically what I want you to focus is you have to remove the calculus or whatever accretions that are present on the lateral aspect of the root that is causing the periodontal problem. Another case, look at the gingiva here. Look at the color, look at the demarcation of gingiva here. You can see definitely there is a deep pocket here. It's a bluish hue. Look how well it has healed. Maybe the photograph difference is there, but still that is there throughout this area. But look at how well it's healed and after surgery. Same patient in relation to this aspect. How well it is healed after surgery. There is recession. Of course, the recession is increased after surgery. But look at the gingival tissues. Now, this is what we want. Even after doing a radiotropic use, we want our gingiva that is probably knife edge, that doesn't bleed, that is really healthy. So that is what I want all of you practitioners to concentrate upon. Now, we now have WhatsApp and email. And now the main problem is someone will be sending you one radiograph and then asking you to diagnose and give a treatment plan. To be honest, I cannot diagnose a single case based on a radiograph. Now, the reason is there, and I'm going to show you the reason. Now, somebody sends me this radiograph here. Now, according to this radiograph, you know, almost probably about middle third of this bone has been lost, of the root bone is lost. You can see a horizontal type of bone loss. Now, does this patient need any treatment? Now, this same radiograph can present in different ways clinically. I'll show you that. Now, look at this scenario. Look, this is the bone level. This is the bone level. But this is the soft tissue level. So if the soft tissue is here, you have a pocket here. Pocket may be probably 6 millimeter, 7 millimeter. If it is 6 or 7 millimeter, probably you'll have to do a surgery here. Now the same radiograph can present like this. There is some amount of gingival recession. The bone is at the same level as here. And you may find a pocket of probably 4 millimeter with some calculus or something. No calculus. What is the treatment? You can do non-surgical treatment. Now, the same case, same radiograph. Look, there's a lot of recession associated with that. There is no pocket. You don't have to do any treatment. So if someone sends me this radiograph and asks me to diagnose a periodontal problem and propose a treatment plan, how can I? Pocket is a soft tissue change which cannot be seen in a radiograph. That is something that every one of you should understand. At least, if you take a radiograph, if you send a radiograph to your periodontist, take a clinical photograph of that area and send to, so that he will have a good idea. And better, you take after etiotropic phase and send. Then probably at least looking into that area. He may not give an exact diagnosis, but he can really give a diagnosis and treatment plan which will fit about 80 to 90%. Same thing, mobility. Now suppose, just people will say that this patient of mine has got grade 1 mobility. Doctor, some other person will say that this patient has got grade 3 mobility. But just because it is grade 3, do we need to extract the tooth? No. Look, this is a case. And suppose this patient has got grade 2 or grade 3 mobility. Look, there is a whole lot of gingiva that is covered in this area. You have this is a type of horizontal bone loss, but at least you can try to bring about some amount of reattachment here. Now here it's a recession. So the prognosis, when you compare from this, is less. And here there's complete recession. You can't do much as a periodontist here. There is it's grade 3, or in this case, like there is too much recession extending almost to the apex. You can't do, you probably have to extract this area in case of mobility. In this case, if it is grade 3 mobile, it was like this. Then you can try regenerative techniques. You can try to save that tooth. So it is not just mobility. It is not the bone loss that you see on a radiograph. That is going to determine the prognosis of that tooth or the overall dentition of that individual. You have to correlate all these aspects. One important aspect is the gingival level. Okay. Now this same thing. Why we did? If you take a radiograph and see this case, even before root canal therapy, oh, he's got circumscribed radiolucency. It's a grade 3 probably. It's not grade 3, it was grade 2 only. Grade 3 also. In 3 means we will splint it and do it. But we didn't. Because why? Because we had only recession here a little bit. If the recession was extending almost to the apex here, we would have extracted the tooth. We wouldn't have done any surgery here. Now, another aspect which I want you to take care is common is periodontal abscess. Now, periodontal abscess is often mistaken for periapical abscess or a periodontic problem. And I have seen many people in their practice doing root canal treatment for a periodontal abscess. And after doing root canal treatment, the abscess is not subsiding, and they'll refer to a periodontist. So basically, you have to know how to manage a periodontal abscess. But whenever I'll tell you the difference between how to differentiate between a periapical and a periodontal abscess. Now, periodontal abscess is one thing about periodontal abscess is you will have a vital tooth. And in relation to a periodontal abscess, wherever the abscess is there, if you probe, that probe will pass and it will go to that aspect of the abscess. In case of a periapical abscess, your probe is not going to go there. Your tooth is non-vital. Your tooth will have some sort of caries. It may be discolored. It is a non-vital tooth. It may have a history of trauma. That is something major difference between a periapical and a periodontal abscess. Then periodontal abscess may be seen anywhere along the lateral aspect of the root, while a periapical abscess is usually seen in relation to the most apical aspect of the tooth. So these are the basic. Along with that, you can say pain. Pain on percussion is more vertical percussion is there for periapical abscess, while it is more for horizontal type of percussion pain is there for periodontal abscess. And periapical abscess mostly there because of the endodontic origin, the severity of pain is mostly towards the night, in the night. So these are the basic differences between a periodontal and a periapical abscess. I've seen many people confused in this regard. That is why I added this part regarding periodontal abscess into this presentation. How do you manage periodontal abscess? Now, suppose if it is periodontal abscess, one, if you have a fluctuant abscess, you have to drain. Like any other, the most fluctuant area, you put an incision and drain. Do we need to give antibiotics in all cases of periodontal abscess? Yes or no? There is absolutely no need for giving antibiotics in all cases of periodontal abscess. If you have a systemic problem associated with the abscess, you have fever, malaise, lymphadenopathy, probably you can give. Otherwise, if the patient has got any systemic problems associated, if you've got diabetic, got an immunocompromise, probably you'll have to give an antibiotic. Otherwise, you just have to drain the abscess. And what has caused the abscess? The abscess is caused because of plaque and calculus, as I said before. So try to remove that. Remove it by non-surgical means, if not by surgical. And then just put the patient on supportive periodontal care. What will usually, how does many of us manage, not me, many of you are probably general dentists or non-periodontists, let's say. Mostly what they'll do is scaling and give an antibiotic, or they'll give an antibiotic. When it's upset, they'll recall the patient, do a scaling, again send the patient. After 4 or 6 months, again an abscess will come, the patient will come, probably will check the blood sugar and say that blood sugar is contributing. Sometimes the blood sugar can be normal also. But what you should know is, with each episode of this acute abscess, there is bone that is going to be eroded. So with each episode, the prognosis of that tooth is getting low and low. So that is something you should know. Now, another thing that you should know is, especially you may find some sort of a similar to a periodontal abscess, you may find a lesion in relation, especially mostly a crown tooth. You may find an abscess like this. But you look into all other aspects of the tooth, you may find no pocket here. But here, you may find the pocket that is extending there. You also are concerned. You take a radiograph, you find that there is bone loss here. It's endodontically treated, and look at the endo. There's no periapical radiolucency. Fine. But you will know that there is something that's wrong here. What is wrong here? It will be mostly a case of fracture tooth. It will be a vertical fracture, post-endo. And because of its vertical fracture, you may not be able to detect in a radiograph. You may have to make a CBCT. This is commonly. Only thing is you have to extract the tooth. Nothing else. There's no other treatment so far for vertical fracture. Now these are my last slides. Okay. Now this is there's a personal case of mine. This is a 27-year-old male patient that came to me last December, 2020 December. This patient came all the way from Trichy. He had referred many dentists, and many dentists have advised multiple extractions for this patient. And if I can tell you, I don't have a clinical picture. This is my clinical case. That's why I don't have clinical picture. I don't take clinics. I mean, only the cases that we do in college we do. That is a fault that I and many of many of the listeners do share. Now, this patient was very worried because he's only 27 years old, male patient, young. And we took a medical history. Already people had a lot of advice and a lot of blood tests. And it was all non-confirmatory. There was no absolutely, everything was within normal limits. So based on, if you look at this picture, because there is no clinical picture, I can say that what I have to tell you is there was no recession in relation to this teeth. And this teeth, that is 3-6, was about grade 2 mobile. This was grade 1 mobile. But you can see that the rest of the teeth, especially in relation to this advanced bone loss, were about grade 1 mobile. But the good thing about here was there was no recession in relation to these teeth. So I told him, the treatment plan I told him was, look, I will remove the poly wisdom tooth, but I'll try to save all the other teeth. He agreed for that. And because there was a periapical infection here in relation to these two teeth, I advised an intentional root canal. I didn't even check for vitality of these tooth. I had a doubt whether the lesion was extended the apex of this tooth and these. So I told him, anyway, we'll do a surgery. If needed, we'll do a root canal. That was what I told him. It's slightly different from what is given in textbook, but this is what I do in my practice. Now, this is 5.5 months, probably 3 days before he came back. I asked him to take an OPG. Now, this tooth was not extracted. The first cordon I did was here. And during this time, he said he was like psyched and he told, like, I'm losing tooth, sir, please don't extract it. And I told him, whatever happens here is your fault. It's not my fault. And I was really scared because this was the area where there was the most advanced bone loss. But you can see the other areas, I convinced and extracted in this area is there. And when you compare the pre and post-op, this is just after 5.5 months. I am really happy with this case because you can see there is some amount of bone gain in relation. You can see that that radiolucency has greatly reduced. This only, if you take a OPG after 1 year, I can definitely say that there will be good amount of dense bone over here. You can see that the bone is there over here. The periapical radiolucency or periapical problem is a result. And we are going out the further treatment, that is, we are going to do crown on these two teeth and going up for our treatment. So suppose the idea that I want, the message that I want to convey to you, many people will look into the radiograph of this case and said probably extract. That should not be the dictum. You have to look at the other aspects. One aspect which I always looked was after the scaling, the gingival tissues were responding well. And the patient was very keen on maintaining oral hygiene. So these two things really helped this case also. That is something that I have to say here. So it is not only the amount of bone loss or the mobility in relation to certain teeth. It is all these factors combined with recession, the ability of the body to against inflammation, how well it is combating the inflammation after removing the etiological agents, and the ability of the patient to maintain good oral hygiene. If everything is there, then you can do wonders in many of the periodontal patients. Now, the common mistakes that we make is, as I told you before, we don't give much importance to the gingiva. We don't observe the gingiva. All this inflammation is taking place in relation to the gingiva. Only the caries is taking place in relation to the tooth. We give a lot of importance to the shape, size, the alignment, all those things. We lack an observation regarding soft tissue. So that is one thing that we have to change. You have to change. Second is importance of scaling. Scaling means not just removal of calculus, which is seen probably by the patient, no. Which is not seen by the doctor, no. You have to search and remove calculus. Search all around the tooth. Look for deposits or feel for deposits and then remove. You should not delay treatment. And the younger individuals are not diagnosed. That is the most important problem. You are seeing that patient, but probably after 20 years, you see that the same patient as a full-fledged perio patient, and then you diagnose the case, and then you send the periodontist where he has nothing to do. So the take-home message here is diagnosing early is the key. You have to diagnose early lesions, and for that, what you do? Observation. Keenly observe the tissues. Use your clinical acumen, then use a periodontal probe. Calibrated good periodontal probe. Thorough scaling means complete removal of the scalpels. And your mobility or the radiograph, the bone loss in relation to radiograph is not the determinant for taking a treatment plan, making a treatment plan. And when in doubt, always there are specialists around. There are a number of specialists, I think, who are listening today also, which can help you. They're all from this region. Take their help. Well, this patient, a person has been practicing, who's hearing this has been practicing for 20 or 30 years, definitely. I'm pretty sure that you would have seen this patient at this stage progress into his gingivitis stage. Into this stage, but still he has not identified the problem, and he has identified the problem here, and he's referring that patient to a periodontist where the periodontist is helpless. So it is you, everything is in your hand to identify the cases as early as possible, intervene as early as possible, and if not, there are always patients take care of things. But again, the thing that I want to reiterate here is diagnose early, not an advanced case. Now, everything becomes good when the pink and the white blend in perfect harmony. It is just the white, it is not going to be aesthetic. So only when the pink and the white blend in harmony, it's going to be totally aesthetic, totally satisfying the patient, and moreover, it is going to be totally satisfying to you as a dentist. Now, this is where I've been working for the past 20 years. All my life has been over here. I have a number of friends who are my colleagues also watching this lecture here. And I'm really thankful to IDM Malanat, office bearers, executive members, especially the CD chairman, for inviting me to be a part of this program. And I hope, before when I started, I told that if someone, at least 10 of you, are able to identify an early periodontal problem and propose a treatment plan for that problem, then I've done a good job. I think I've done a good job. I hope so. Thank you.
Thank you, sir. Sir, there's one question in the chat box.
Yeah, hello. Can you hear?
Yes, sir. Yes, sir.
Yeah, I saw that question. It was regarding mobility after scaling and sensitivity after scaling. Now, one thing I think I have to tell you is like when there are too much calculus, probably the condition what you probably are saying is the calculus is mainly causing or reducing the mobility of that tooth. Actually, when you remove the etiology, what happens is, even though in the initial stage there will be a little bit more mobility, the same is there along with after periodontal surgery also. Whenever immediately after surgery, usually the tooth will be more mobile than what it was before. The same is with some cases in which there is slight mobility, and when you do a scaling, sometimes the mobility increases. But you follow up those cases. Now you follow up the cases for 2 or 3 weeks, and you can see that this mobility will reduce over a period of time. And one thing regarding sensitivity doesn't occur to all the patients that you scale, especially where there is recession and the roots are covered by means of calculus. You remove that. In such stages, usually the tubules get exposed, and probably that will result in sensitivity. One thing you should advise patients in such a way, one thing you should advise the patients is that the patient should maintain meticulous oral hygiene. Now, one of the prime reason why there is sensitivity immediately after scaling is because the irritants, again, the different types of irritants and acids produced by these microorganisms. So if the patient is able to maintain good oral hygiene, that itself can reduce sensitivity. At the same stage, if it is an advanced case, probably you can advise him some desensitizing paste. So that is how you have to go about mobility and sensitivity associated after scaling. I think
Sir,
there was
one more question.
Yeah. Yeah. The question was how many days, weeks after etiologic phase do we have to reevaluate? Now, the ideal thing is you wait for 1 month. You do a meticulous scaling followed by your subgingival scaling. And then if you can wait for 1 month, that is the best. After 1 month, you have to reevaluate what are the points I told you before. You have to look at the gingival condition, the periodontal pocket, how the patient is responding, how these tissues are responding, how he's maintaining oral hygiene. Everything has to be assessed after 1 month, and then you plan your further periodontal treatment.
The next question, sir, does the flap surgery cause gingival recession, especially in the anterior region?
Now, one thing, Dr. Charlie, is look, whenever there is a pocket, the gingiva is not in relation to the bone. The thing about the gingiva is whenever you are removing all the etiology, when you are removing the causes that contribute to the inflammation there, the gingiva will shrink and then come and attach to the bone. That is how the reduction in pocket takes place mostly. So if you have a bone loss, especially interdental bone loss in relation to your anterior tooth, most of the cases, it is going to result in some sort of recession. So when we do the cases, in most of the cases, in anterior regions, we try to do a minimally invasive type of periodontal surgery. That is one thing that we can try. Or at the time of surgery itself, we try to make put the flap or place the flap more coronally and suture, so that this can prevent this recession to an extent, but not in all the cases. I hope I've answered that. There's one more case, one more question. In many cases, we can see severe recession, space, mobility, and calculus in relation to lower anteriors. How it's caused here? Anything related with lower frenum and its attachment. Sometimes with central incisors are affected first, and if they are affected after 2 to 3 years, laterals are seen affected. Now, one of the main reasons why you find most of these problems in relation to the lower anteriors or calculus deposits is because of the salivary gland duct opening there. And that is where you have more of these deposits. And that is along with that, if you have all these mucogingival problems, say if you have a frenal attachment, along with that minimal width of attached gingiva and the patient can't maintain well, this is going to complicate the problem. And look, the patient is not, you are removing that central incisors, and then your patient is not educated, or you have not advised the patient proper brushing technique, follow-ups, and that is why you are losing this other teeth in 2 or 3 years. So that is what that is the patient is not maintaining well.
So the next question is the drug choice in pregnant and lactation patient who is allergic to penicillin.
Usually, we give clindamycin, but in pregnant woman, I stand to be corrected here. I'm not pretty sure. In case of penicillins, we use, you can give that. I stand to be corrected on this.
That's all the questions, I think, sir. Yes.
A question, Joseph.
Yeah.
In endo and perio lesions, should we go for an RCT or should we start with the perio treatment first, then go for the RCT? What is your opinion?
Look, in endoperio lesions, if it is a there is a true communication between the periodontal space and the endo, that is with the pulp. Now, the thing is, you have to invariably do a root canal first and then do a periodontal treatment. The reason why is, when you're doing the periodontal treatment, you are actually making the pocket sterile. Okay, the root surface sterile. You are removing all the deposits, all the microorganisms from there. But you have an infected root canal, and in the infected root canal, it's completely filled with microorganisms. And the moment you close the flap, everything from the apical foramen, whatever communications are there between the pulp and the periodontium, the microorganisms come and translocate this area, and again the pockets will be there. So you have to, at least if you do a initial phase of root canal treatment, even before obturation, that is fine. You have to do a surgery only after that.
Sir, one more question. Periodontic consideration for closing midline diastema.
Look, it depends upon what is the cause for diastema. The diastema may be, in the earlier concept was the diastema was caused as a result of frenal attachment, higher frenal attachment, but that is not the case. It's actually the other way. Now it is because the tooth, there is a thick interdental bone between the anteriors, which has prevented the tooth from closing, and as a result of that, it has resulted in this frenum. So usually we advise frenectomy in these cases if it's going for an orthodontic treatment, and we do the frenectomy probably after the tooth movement is completed. Now, I think if it is diastema related to probably pathological migration, depending upon the advanced bone loss in relation to that case, you have to take a call, you have to manage pockets, and then if such teeth can be brought by means of some extensive endodontic and prosthetic work, you can close the diastema in such way. But the simple case of diastema, basically, like you don't really have to do a frenectomy because your frenum is not the real reason that has caused the diastema.
One more question regarding the deficiency of vitamin D. Does it cause periodontitis? Read it in an article. Is that?
It can. Look, it is. There are a lot of studies where you can say that vitamin D, sunshine vitamin deficiency can lead to this bone alterations, and it can lead to periodontitis. But you can't say that just because vitamin C is deficient, it is.
Vitamin D.
Yeah, vitamin, not C, sorry, vitamin D. This is not going to this thing. But there are a lot of studies which point out that there is more of periodontitis associated with the deficiency of vitamin D.
I think, sir, only that much questions. Thank you, sir, for such a wonderful presentation. It was indeed a crisp and clear lecture. Such a vast topic made into simple and well explained yet. Thank you so much, sir. I thank Dr. Deepak Kalarikal, President IDA Malanad, Dr. Pradeep George Phillips, Secretary IDA Malanad, and all the members for the support. On behalf of IDA Malanad, we thank all the participants for your valuable time. Thank you so much. Thank you, sir. Thank you so much. It was
Thank you.
well explained.
Thank you, Dr. Maushmi, Dr. Deepak, and Dr. Pradeep. Thank you.
Thank you, Doctor. It's very informative.
For all the members of IDM Malanad, there's a small announcement. The Hope Ashwa renewal has been started since yesterday, and the date of last date of renewal is 7th of July. So kindly make use of this available time to renew your Hope Ashwa. One. Second is, if at all anybody is planning to take Hope Ashwa this year, they have to take it before 7th of July. I hope everybody knows about the importance of Hope Ashwa, where your professional indemnity, then your clinic insurance, your residence insurance, etc., can be done through that. So kindly make use of it and do it as fast as possible so that you don't regret later. Thank you. Thank you all for coming and making this session a great one. We are ending the meeting.